We're so excited that you're here with us to learn a little bit about what our presenters are doing in the endocrine system. We are joined today by 5 of our wonderful physicians in this area, and they'll introduce themselves as they get started here in a second. But before we get started, I want to just give you a few technology tips because I know this is a little bit different from what we may have done before. The first is that there is actually a live transcript button down at the bottom of your screen. So if you don't want to see that live transcript, just go ahead and click that live transcript button and you can turn it off. If you do have questions for our presenters tonight, please utilize the Q&A box. You can upvote questions that you want to see us answer. And we will try to get to those at the end of our presentation today. There will be some polling questions. I believe just one at the beginning that comes up here in a moment for you to answer. There are back in the main page of ResearchCon session resources for you to go back and look at if you have questions or anything else like that. Mike, can you go back one slide for a second? I wasn't quite there. If you want to talk to everybody else in the session, there are quite a few of us here tonight. We're up to about 68 right now. There is a chat box down there. That's where you can talk to each other about anything that you desire. If you're having technology problems, you can always go back to the main session and they will be able to help you with that from the CF Foundation. Please remember that this is a big session on endocrine. So we have many different things we're going to cover today. Mike, you can go ahead and a slide. This is a very broad topic, and so we are going to be covering things that may be sensitive for some young ears, particularly when we get to the reproductive section in a little bit. If you are here most interested in the CFRD section, there is a roundtable on Saturday in the afternoon that you are more than welcome to attend. I'll be leading that session with another couple of our researchers in the area, and we're really excited about that. So please feel free to come back for that one. Please do refrain from giving medical advice in the chat box. This is not somewhere where we can do that. It's also very much advised that you please talk to your care team about what will be best for you. I believe that's all I have for you. Do we have that poll question, Jen, that we can pull up for this session? Perfect. So what part of this session are you most excited about? This should show up on your screen. You can go ahead and click whichever one you are most excited about. Awesome. Thank you guys so much for continuing to respond. Unsurprisingly, it looks like CF-related diabetes is our top winner here. But yes, that was a Dexcom alarm, Haley. It's mine. I'm sorry. It's going to go off here all night. But we are so excited for this session. And I'm going to go ahead and turn it over to Dr. Mike Selvey, and he's going to start us off tonight. Thanks for being here, guys.
Good evening. It is my pleasure to welcome everyone to ResearchCon 2021 and our session tonight entitled Endocrine is Everything, Diabetes, Growth, Puberty, Sex, and Bones. My name is Dr. Michael Stalvey, and I'm a pediatric endocrinologist at the University of Alabama at Birmingham, where I specialize in the endocrine disorders of CF in both kids and adults. The focus of my section tonight is on growth and puberty in CF. Before I begin, I'd like to disclose that I'm currently a consultant for the CF Foundation and on the medical advisory board, medical advisory board for Ascendis Pharmaceuticals. Additionally, I have past research funding in growth hormone research from Genentech and served on the medical advisory board for Vertex Pharmaceuticals. The objectives for my talk tonight are as follows. Number 1, discuss growth impairment in CF, the significance and possible reasons for it. Number 2, I will detail some of our experiences in clinical research focused around growth, as well as the impact of CFTR modulators. Number 3, we'll briefly discuss puberty and pubertal timing as it pertains to CF. And 4, finally, we'll discuss the future gains and knowledge of growth impairment that we expect to come in CF from ongoing studies and those planned for tomorrow. To begin my talk, I'd like to illustrate the problem of poor growth and the significance of it in CF. In doing so, I'd like to introduce you to Joseph. Joseph is a young man with CF that I've taken care of for many years now. Here you can see him standing in the far right of the picture with his family at 13 years of age. His parents are both 5'9" tall. His brother on the far left is 5'11" and is only a year and a half older than he is. His sister is in the middle of the picture, and she's actually 5.5 years younger. When I first met Joseph, he was struggling with his weight and was admitted to the hospital almost every other month. We'll come back to Joseph in a minute after we discuss growth and some of the treatments for growth. Growth restriction, or problems in linear growth, are almost universal in CF in some degree. For the longest time, our community was so focused on BMI, given, well, that is directly proportional to better lung function, so that's understood. However, this resulted in overlooking the heights of our CF children and adolescents for many years. Furthermore, very poor growth, referred to as stunting, or growth less than the 5th percentile, is actually an independent predictor of mortality in CF. The table on the left demonstrates weight for length, weight percentile, and length percentile in children less than 2 years of age. The table on the right demonstrates BMI percentile, weight percentile, and height percentile in those between the ages of 2 years and 19 years. You can see on the table on the left that the length percentile for children under 2 years of age is only about the 30th percentile. And then on the right table, which is those individuals between 2 years and 19 years, the height percentile is only at the 38th percentile. Well, when is growth impairment impacting CF children the most? The data would suggest even very early on. In the BONUS study, or the Baby Observational and Nutrition Study, 231 CF infants were identified by the newborn screen. The two graphs represent weight on the left and length on the right, with the age in months along the bottom of the graph. These infants were compared to the average of non-CF infants, which is represented by the 0 line on both graphs. We discovered that both length and weight were decreased by 1 to 3 months of life. And through aggressive nutrition, weight returns to that of average healthy infants by 8 to 10 months. However, linear growth does not, and it continues not to catch up by the first year of life. Unfortunately, care providers frequently disregard early growth impairment in CF and do not recognize the significance of growth rates in the first few years of life. In a comparison we did of early childhood growth with adult height outcomes, we evaluated over 3,000 young adults. Our analysis revealed that a height below the 10th percentile at least once between the ages of 2 and 4 years was very predictive of an adult height below the 10th percentile. Additionally, almost 60% of children between the 10th and 25th percentile between the ages of 2 and 4 years went on to be below the 25th percentile as adults. Well, what are some of the potential causes of poor growth in CF? Nutrition and undernutrition must be considered first and foremost. Next, reduced anabolic hormones involved in growth, primarily seen as reduced IGF-1, which is the downstream product of growth hormone. CF-related diabetes and the insulin deficient state, because insulin is another anabolic hormone that stimulates not just weight gain, but also bone growth and bone health. CF-related liver disease can contribute to the reduced IGF-1 levels as well as the chronic disease state. Chronic inflammation from recurrent exacerbations and chronic corticosteroid use have direct effects on the growth plates of your bones? And finally, is there an impact of the CFTR transporter itself on growth in the growth plate? Well, as an endocrinologist, I'm often asked, does growth hormone treatment help? Studies on the use of human growth hormone, or HGH, in CF have shown an improvement in height, weight, and lean body mass. The graph on the left shows an improvement during a 1-year study of CF children treated with growth hormone in the dark line compared to those that were in the observation arm in the lighter gray line. The graph on the right shows an improvement in weight in the light gray of both those observed and those treated. The observed ones are on the left, the treated ones are on the right. And lean body mass in the dark gray or black bars of both the observed kids and those treated with growth hormone. Both groups saw an improvement in weight and lean body mass. However, it was greater in kids treated with growth hormone, as seen in these two bars, and the weight improvements were primarily lean body mass. Now, I want to pause for a second and return to Joseph. Here's the picture I showed you earlier with his parents, brother, and sister. Now, I show you a recent photo of the same family. And again, Joseph is on the far right. He is now the tallest in the family. As you can see, growth hormone dramatically helped him out. He went from a struggling young boy to one who played varsity football in high school and is currently thriving in college. He in turn invested heavily into exercise and weight training as part of his health regimen, which further aided in his growth and weight, as well as his other parameters of health. The graph on the far right demonstrates the changes in height on the blue line, weight on the red line, and BMI in the green line over time. The green arrow at the bottom demonstrates when growth hormone was initiated, and the red arrow demonstrates when his weight training and exercise training was initiated. Well, what about the direct impact of CFTR and CFTR modulator treatment? On this slide, you see the results of the nearly year-long ENVISION study of Kalydeco in CF children with the G551D genotype, compared to CF children with the G551D treated with a placebo. The graphs demonstrate improvements in CF children treated with Kalydeco for both weight on the left graph and height on the right graph over those treated with the placebo. These Kalydeco kids are in the dark solid line in both graphs, and those treated with placebo are in the dotted lines on both graphs. This graph of the previous data demonstrates more specifically the changes in growth, both height and weight, in children treated with Kalydeco versus those treated with placebo. The height velocities are on the left in centimeters per year, with placebo in the light gray and ivacaftor or Kalydeco treated children in the dark gray. And in weight on the two bar graphs on the right, again, those treated with placebo in the light gray and those treated with Kalydeco in the dark. You can easily see the improvements of both height velocity and weight velocity after treatment with Kalydeco. Although these studies do not detail a mechanism for the reduced growth seen in decreased CFTR function, it does demonstrate an increase, either directly or indirectly, through the improvement of CFTR function. I'm going to switch gears now and briefly discuss puberty in CF. Prior to recent reports, puberty was frequently delayed in CF. This finding has many implications, not limited to just growth and bone health, but also many other things, such as body image. Delayed puberty is defined as a lack of breast tissue development in girls by the age of 13 and the lack of testicular enlargement in boys by the age of 14. More recently, though, Due to improvements in nutrition and also CFTR function, puberty appears to have a more normal timing compared to other children without CF, and a delay should be considered as something that's not just expected normal anymore. Furthermore, increasing weight to the point of being overweight or obese children may bring about early puberty in CF, like that is seen in non-CF children. To close, I would like to mention the future of growth and puberty research in children with CF. Two large studies that I have the pleasure of being part of and encourage your participation in include PROMISE and BEGIN. Many of you may be familiar with PROMISE, which has been collecting data on adolescents and adults with CF treated with Trikafta. It is now also focusing on the younger child, ages 6 and above, which will provide key data on growth and growth factors in this pivotal age. BEGIN is a study recently launched to help understand the natural history of many factors, including growth in CF infants and the very young children before and after the initiation of Trikafta. In closing, I'd like to thank you for your participation and attention tonight. Please stick around for our upcoming talks and continue to submit comments and questions. I'll be back at the end of this session and hope to address some of them with you. Now I'd like to introduce our next speakers, Dr. Kara Hugen and Dr. Tracy Kazmersky.
Hold on here. I'm having a little trouble. Sorry about this. I'm not expanding to full screen. All right. Thank you, Mike, for the introduction and a nice lead into some of the aspects that I'll be covering this evening. The objectives of my session tonight. First, I'm going to share Dr. Kazmersky's disclosure slide. But my objectives tonight for this session are to recognize the role of congenital bilateral absence of the vas deferens, or CBAVD, in male infertility in CF and its management, review the etiology and consequences of male hypogonadism in CF, and know its management. And then I'll end this evening reviewing the pathophysiology, evaluation, and management of reduced fertility in women with CF. Although greater than 98% of men with CF have congenital bilateral absence of the vas deferens, or CBAVD, it's an underappreciated condition impacting male infertility in CF. And this warrants shared discussion between CF care teams and their patients. CBAVD, I sort of think of as a plumbing problem, where men still produce sperm, but there's an absence or an atrophy of certain structures, including here the epididymis and the vas deferens, or these tubules, that are responsible for the maturing and transport of sperm from the testis, and then a absence or atrophy of a third structure, the seminal vesicle, which is important for producing and storing fluid that becomes semen. And this ultimately leads to the sperm being blocked in their typical pathway out of the urethra, resulting in what's termed an obstructive azoospermia. The good news is that there are assisted reproductive technologies or techniques in which sperm can be aspirated or extracted from the epididymis or directly from the testes. Current research suggests, however, that only 1 to 6% of men with CF are receiving this particular type of fertility treatment. Once sperm are harvested from a technique such as this, they can be cryopreserved or frozen, or they can be freshly used to fertilize their partner's egg through a technique called intracytoplasmic sperm injection, outlined here, also termed ICSI. Reported pregnancy rates with ICSI are 30 to 50% per cycle. In addition, men with CF may want to consider partner screening for CFTR gene mutations. In addition to the infertility that impacts men with CF are also at risk for development of hypogonadism. And this is where the testes themselves may not adequately manufacture testosterone, or the message to the testes from the brain do not signal correctly, leading to lower testosterone concentrations or levels. In adolescence, this can impair pubertal development. Sort of a second reason we may see this, in addition to what Mike had shared. And it can delay the appearance of secondary sexual characteristics. In adults with men with CF, this can reduce muscle mass and bone mineral density. And it can decrease one's sex drive and lead to fatigue, depressed mood, and loss of body and facial hair. There are essentially two major etiologies of hypogonadism in CF. First, systemic processes or conditions, including recurrent infections from exacerbations accompanied by chronic inflammation, as well as frequent glucocorticoid administration, may impact that brain to testes signaling, resulting in hypogonadism. A second etiology includes defective CFTR expression in a region of the brain called the hypothalamus, where hormone signaling begins, as well as in key end organs and structures, as well as cells within the male reproductive tract and in the precursors to mature sperm. In addition to a careful physical examination and history taking, we include a hormonal evaluation to diagnose hypogonadism, and potentially other labs and/or imaging to investigate underlying reasons for the hypogonadism. And this slide will be available to those interested in looking at this more carefully in your slide decks. The treatment of hypogonadism includes testosterone replacement. And there's a variety of options that are currently available, including transdermal skin patch, topical and nasal gels, tablets, injections, and implants, as well as a new oral testosterone that's available. We then monitor blood testosterone 2 to 3 months after initiation, and then every 6 to 12 months thereafter. As we navigate into women's health and fertility, I'd first like to clarify the definition of infertility, which is the inability of a couple to conceive after 12 months of regular sexual intercourse without the use of contraception in women less than 35 years of age. But that shifted down to 6 months in women 35 years or older. Infertility in women with CF is multifactorial, and is most commonly associated with suppression of female hormone signaling and feedback at the level of the brain, and this can lead to decreased frequency of ovulation. Contributors to this suppression include recurrent infections and chronic hypoxemia, undernutrition, increased energy expenditure, chronic stress, as well as poorly controlled diabetes. Similar to men with CF, defective CFTR in the female reproductive tract may contribute to infertility. Defective CFTR in the lining of the cervix promotes production of cervical mucus that is thick and dehydrated, which can block the opening of the cervix and impair sperm entry. Defective CFTR in the lining of the uterus, called the endometrium, alters bicarbonate secretion, which can reduce uterine fluid volume and impair sperm fertilization capacity. In addition, women may have lower ovarian reserve compared to their non-CF age-matched controls. When women with concerns of infertility are referred to their women health partners, such as OBGYNs, and in addition to a careful medical history as well as physical examination to uncover the possible contributors to hypogonadism, ovulatory function is assessed, and the female reproductive tract anatomy is examined through imaging. There are medications, including clomiphene citrate or Clomid, and or injectable gonadotropins, such as LH, that can be utilized to stimulate the female's ovaries to produce follicles. And then this can be combined after with the use of intrauterine insemination to help bypass the thick cervical mucus. Finally, in vitro fertilization, or IVF, is an additional option to consider should the less invasive techniques fail. Of course, IVF is more costly, but it comes with it the offer of pre-implantation CF genetic screening of the available embryos. So these treatments have not been very well studied in cystic fibrosis, and therefore the impact of these treatments on the health of people with CF is unknown. So tonight I end with a few summary points from my presentation. And now I'd like to pass the baton on to Dr. Tracy Kazmierski, my colleague here also at the University of Pittsburgh, who's a pediatric pulmonologist. And she's going to be extending this discussion tonight to cover additional sexual and reproductive health concerns of people with CF. Thank you.
Wonderful. I too am going to get my slides up. Just bear with me for 1 second. You're going to see my crazy desktop, and I apologize for this, but I can't figure out how to share otherwise. Are you guys seeing this correctly? I hope you're not seeing my desktop. That'd be horrible.
We see it.
Okay, perfect. So as Kara mentioned, thank you so much, Kara. My name is Tracy Kazmierski. I'm a pediatric pulmonologist here in Pittsburgh. And I'm going to talk tonight about two things. One, I'm going to spend a very brief amount of time really reviewing the range of sexual and reproductive health concerns for people with CF. And I'm going to spend the bulk of time highlighting ongoing and planned sexual and reproductive health research within CF. So As this group knows, people with CF experience both general and disease-specific sexual and reproductive health concerns, and there's a big range of them. A lot of them were highlighted here tonight already, including puberty, testosterone deficiencies, fertility for sure. But as you can see, people with CF experience changing symptoms during the menstrual cycle, yeast infections, urinary incontinence, sexual functioning concerns, issues with contraceptive choice, and issues around pregnancy as well as parenthood. We're not going to have time to go through all this tonight, but I really wanted to highlight that this really is largely an unexplored area of research. And it's quickly evolving in the era of highly effective modulator therapy, and how that therapy impacts sexual and reproductive health still really remains largely unknown. What I'm going to try to do tonight, and I'm going to try to talk uncomfortably quickly, is to highlight some ongoing and planned research related to sexual and reproductive health in the CF community. There's going to be additional studies that I don't have time to cover, along with contact information and educational resources that are available in the supplemental materials. So I encourage you to look there as well. The first study I'm going to highlight tonight is called Mayflowers, and this is the maternal and fetal outcomes in the era of modulators. The primary objective of this study is to really look at the effect of pregnancy in the setting of CF on maternal health outcomes, delivery outcomes, and fetal outcomes, with a big focus on the impact of modulators on these outcomes. This is going to be a prospective observational study that's going to be run through the CF Foundation TDN for all people with CF ages 16 and older who are pregnant. So stay tuned as this gets going. The second study I want to call out is called Case for CF, or the assessment of contraceptive safety and effectiveness in cystic fibrosis. The objective here is really to determine whether pulmonary exacerbation rates vary significantly between people who use hormonal contraception and non-hormonal contraception. And this is really going to use survey data from participants and pair that with CF Foundation registry data. This is going to take place again at around 10 CF centers for all people with CF who meet these criteria, age 18 to 45. And this is also right in the process of getting going at most sites. Next study I wanted to highlight really piggybacks a little bit on what Kara talked about around CFTR and cervical mucus. And Dr. Rowe out of Pennsylvania and in Philadelphia is looking at cervical mucus quality and comparing it between women with CF on Trikafta, women with CF not using modulators, and then women without CF. This is going to be women ages 18 and older, and this is currently enrolling, so there's contact information at the end here. There's also work going on around urinary incontinence in CF, with a primary focus to really understand better the experience of women with CF who have urinary incontinence, and also to perform a feasibility trial of common non-surgical management options for this condition. There's going to be a national interview study that's using CF Foundation Community Voice as a recruiting platform, as well as a feasibility trial at 2 CF centers. And this too is currently enrolling. The last study I wanted to highlight that's really up and running is really understanding the lived experience of parents with CF. I think that we are trying to understand what parenthood looks like for those people who have CF through individual interviews and a project called Photo Voice, which uses photos to encourage conversation and explore the experience of participants. We're recruiting via Community Voice as well, and this is currently enrolling for all people with CF who are parents through any path. And I wanted to highlight 2 projects that are really in planning that think more about what we're thinking about in regards to the health impact of parents with CF. And this is called the HOPE CF study. It would be a retrospective and prospective cohort study at a number of CF centers for all people with CF who are parents. We're still having our applications under review, but it is funded by a foundation planning grant. So we're really hopeful that this can get up and running in the coming months or so. And the last thing I wanted to highlight is around men's sexual and reproductive health and CF. And I think a lot of key work has been done, as you can see, or in women with CF. But I think that we really need to look at the sexual and reproductive health experiences, behaviors, care utilization, and preferences of men with CF, and look compared to the general population, what are men with CF experiencing? So this would be a patient survey, a national CF provider survey around with men with CF age 15 years and older. And again, this is going to be in planning. So we're really hopeful that we can jumpstart this for men with CF as well. And as I said, this is going to be a quick talk, but I really would be remiss without mentioning that there's a lot of things that are still left on the table that we don't understand and we need to do more research on. This is not an exhaustive list, but I wanted to call out that we need to understand more about fertility and male fertility specifically. We need to understand more about testosterone deficiency and what to do about it. We need to optimize the care of those who are intersex or gender diverse in the CF care model. We need to better understand the gender gap in CF, and what I mean by that is the difference in survival between females and males with CF. And we really need to understand, how do we integrate sexual and reproductive health into CF care better? And last but not least, I think that we do need to be asking the questions and searching for the answers to improve the sexual functioning concerns among people with CF. All of this work really must be looked at through the lens of the quickly changing face of CF, as about 90% of people are now eligible for highly effective modulators. And again, I think that this work would be completely impossible without the collaboration and input of people with CF, because they assure that we're asking the right questions and we're asking them in the right way. And I wanted to end with a quote. This is from a 20-year-old woman with CF who I interviewed many years ago. And she said about sexual and reproductive health, "It's always like you just don't talk about it. It's one of those things that's left to the side. It's like they feel it's not as important as everything else, but sometimes it is. I mean, it wasn't life or death threatening, but it could have changed my life a lot." And with that, I'm going to turn it over to Dr. Putman, and we're going to talk about bone health. Thank you guys so much.
Thank you. All right, so I am going to, my name is Melissa Putman. I am an adult and pediatric endocrinologist at Boston Children's Hospital and Mass General Hospital. And today I'm going to spend a little bit of time talking about bone health, the good, the bad, and the promising. If I can, there we go. Really quick, my research disclosures include funding from the Vertex Investigator-Initiated Studies Grant, and then funding from the NIH and CF Foundation. And so over the next 8 minutes, we will be talking about the bad news, which are the effects of steroids in bone and when to worry. And then we'll talking about the good, ways we can try to optimize bone health while on steroid treatment, and when to consider pharmacologic interventions. And then we'll finish up with the promising, the effects of CFTR modulators in bone health. And so steroids are just so good for so many things, including inflammation and bronchospasm, but they're just so bad for everything that has to do with endocrine, including diabetes and bone health. And this is a really nice picture that I think summarizes some of the detrimental effects of steroids on bone. So we see here decreases in muscle mass and sex steroids, effects on calcium homeostasis. Ultimately, steroids can cause activation of osteoclasts, which are the bone breakdown cells, and then suppression of osteoblasts, the bone buildup cells, and then, in the long run, lead to bone loss and fractures. So a question that I often get is, well, how much is too much when it comes to steroids in bones? And it's a tough question to answer because some studies suggest that doses as low as prednisone 2.5 to 7.5 milligrams a day for as little as 1 month can be associated with fractures. In general, we usually start to worry with doses of prednisone more than 7.5 milligrams a day for more than 3 to 6 months. It's usually the threshold. The data about inhaled steroids are mixed, but in general, we feel that inhaled steroids have fewer and less severe effects on bone than oral and IV steroids. And if you think about it, if taking inhaled steroids mean that someone needs less oral steroids, then ultimately that can be very beneficial. And it's also important to keep in mind that for people who are going to be on steroids for a prolonged period of time, it's important to screen with a bone density test or a DEXA scan at the beginning, and then also kind of to watch over time to look for bone loss, and also to consider doing spine x-rays or a vertebral fracture assessment, which can be done as part of the DEXA scan to make sure there aren't any spine fractures. But the good news is that there are things that we can do to try to optimize bone health during steroid treatment. And probably the most important one is really to aim for the lowest, most effective steroid dose for the shortest possible duration. Also trying to ensure a good nutritional status, trying to do as much weight-bearing exercise as possible. Weight-bearing activities really send signals to bone cells to build up bone and can be very beneficial. Really ensuring adequate calcium, vitamin D, vitamin K, and then also, making sure there's nothing else that could be going on that could be contributing to bone loss, like low sex steroid levels or uncontrolled diabetes. And there are medications that are FDA approved to treat steroid-induced osteoporosis. And there are guidelines that are published specifically for people with CF to try to help us decide who would benefit from these treatments. I'd point out, though, that these guidelines, the CF bone health guidelines, are not specific to steroid treatment, but they do recommend considering a pharmacologic therapy if bone density is low with a z-score, a DEXA z-score below -2, for people who are fracturing, have accelerated bone loss, and for those undergoing lung transplant. And oral and IV bisphosphonates are the first-line treatment for CF-related bone disease because these are the ones that have been studied the most in this situation. And so now I'd like to go on to talk about the promising or the effect of CFTR modulators on bone health. And I think everyone on this call knows that CFTR is expressed in the lungs and in the airways and the pancreas, but did you know that CFTR is also expressed in bone cells? This is an example of a study that's showing CFTR here in an osteoblast or a bone forming cell, and then here in an osteoclast, which is a bone breakdown cell. And we don't know exactly what CFTR is doing in bone cells, but there are studies that are suggesting that maybe it has something to do with how bone cells talk to each other to mediate bone buildup and bone breakdown. And so if CFTR is expressed in bone cells and may play a role in bone health, then the next question is, well, do CFTR modulators have an impact on bone health? And I'm really excited to tell you about this study that we just recently published where we tried to answer that question. And so this was a study where we enrolled 26 children and adults with CF who had the G551D mutation right as they started treatment with ivacaftor back when it was first FDA approved. And then we enrolled patients with CF who were not taking ivacaftor, so who had most of them had different mutations, and then 26 healthy volunteers. And all three groups were matched to each other by age, race, and gender. And we evaluated bone health at baseline, 12 months, and 24 months. And we used really cool research tool to do this called high resolution peripheral quantitative CT. And these are two representative pictures right here. And you can see, so HRPQ-CT, basically it's a CT scanner that takes pictures of the wrist and just above the ankle bone, and it gives you all this detail about cortical bone, which is the thick outer shell, as you can see here, and then trabecular bone, which is in the inner part of the bone. And what we found was that adults treated with ivacaftor over 2 years had significant increases in cortical bone, in cortical area, in volume at both the lower leg and at the wrist, as you can see here. And they also had increases in cortical porosity, which is kind of really a sign that there could be increased remodeling or almost like an anabolic effect of the ivacaftor on the bone. And we don't really know what these findings mean in terms of the long-term effects of ivacaftor on bone health, but I think that these results are really promising that CFTR modulators really could have an impact on skeletal health in people with CF. And so as we look ahead, there are, I think, some important questions that we need to answer in the field of bone health. One of those is, what is the best approach for preventing bone loss and fractures in the setting of steroid treatment in people with CF? And do we need to update our CF bone health guidelines to include specifically this situation of people being treated with steroids? Another question is, we have a lot of other osteoporosis treatments available for treating this condition, but they haven't really been studied in any detail in people with CF. And I think this is an important gap that will need to be filled in the years ahead. And then lastly, and most importantly, how will Trikafta affect bone health and body composition moving forward, especially given the findings that we saw with ivacaftor? I think that the PROMISE study that Mike had talked about earlier, which is following DEXA in people being treated with Trikafta, I think that one will be very helpful in answering that question. And so with that, I would like to turn the baton over to Dr. Andy Kelly.
Thanks, Melissa. Good evening, everyone. Thank you for your willingness to stay late in the evening, at least for the East Coast folks. I'm a pediatric endocrinologist at the Children's Hospital of Philadelphia, and I've been working in the CF field since 2005 or so. I first wanted to thank my colleagues for their valuable guidance in preparing this talk. And I've been charged with presenting on CFRD in just about 20 minutes, so it's a big task. And Kristen encouraged me to present research data and not just summarize what many of you already know. And I will do my best to try to make my presentation understandable. As a jump start, I will briefly review the oral glucose tolerance test and the use of OGTT, and I'll use the OGTT as a platform for much of the research I will present. And I will also use the OGTT presentation as an opportunity to weave some commentary on ongoing research initiatives and highlights. And at the end, I will present some of the early data that we have available regarding modulator therapy and CFRD. So as many of you know, the CF Foundation recommends oral glucose tolerance testing annually to screen for CFRD. I'm going to break this apart. The recommendation is annual, and many individuals are wondering if we can do some risk stratification. So based upon someone's age, their previous OGTT, their hemoglobin A1C, which is a marker of blood sugars, clinical status, meaning how they're doing with respect to pulmonary function and nutritional status, whether someone has a family history of diabetes, if someone's on overnight feeds, and if someone has CF liver disease, which we know is a risk factor for CFRD, could we tailor the oral glucose tolerance testing such that it may not need to be done annually, but perhaps every 2 years? I don't have any answer on this right now. I just bring this up as a research question. And it's also recommended that we do an OGTT. And we know that this can be an onerous task. And some of us have looked at use of hemoglobin A1C, which is traditionally used in both type 1 and type 2 diabetes to diagnose for diagnosis and for monitoring therapy. And while we know hemoglobin A1C above a specific threshold is consistent with CFRD, it doesn't, a normal hemoglobin A1C does not exclude that diagnosis. And so some people are looking to see if we should be using a different threshold. So more to come there. Others are using the 50-gram glucose challenge test. And for the mothers in the audience, you may have undergone something like this in excluding the diagnosis of gestational diabetes or diabetes that occurs during pregnancy. And then others are using continuous glucose monitoring, including Christine Chan at the University of Colorado and Bryn Marks at CMMC in DC, to see if that's a better way or an easier way to identify people with CF-related diabetes. And then I think an important question is, this currently needs to be done by age 10 years, but in the era of highly effective modulator therapies, we're hopeful that with early introduction of modulators, perhaps we'll be able to delay or even prevent CFRD, and this age of 10 years might be pushed back. So that oral glucose tolerance, many of you know, you get that fasting blood sugar, you drink your glucola, and you get a 2-hour glucose. Many of us also obtain a glucose at 1 hour because we think that it's clinically relevant. And we know that in people without CF, that a higher blood sugar at 1 hour is associated with greater likelihood of developing type 2 diabetes. And there's also some data in the setting of CF that is also true. So what do those oral glucose tolerance tests look like? Normal glucose tolerance, your peak glucose happens in about 30 minutes. And at 2 hours, your blood sugar is less than 140. CFRD, your blood sugar at 2 hours greater than 200. And then we have more subtle glucose abnormalities. So the impaired glucose tolerance is when your blood sugar is between 140 and 200 at 2 hours. The CF Foundation recognizes indeterminate glucose tolerance. So that's when you have that isolated blood sugar greater than 200 at 1 hour, but completely normal glucose at 2 hours. And then many of us in the CF world and in the non-CF world recognize that it's actually a blood sugar greater than 155 that's associated with early insulin secretion defects. And then when one has a fasting blood sugar greater than 125, that's consistent with fasting hyperglycemia. And that tends to be the subset of individuals who have really severe insulin deficits. And then there's a subset of patients who describe feelings of shakiness or lightheadedness during the day. And what we've come to identify is that there are a good number of patients who actually have low blood sugar after they eat. And I'll present some data on that as well. So what are we learning? One of the questions we've been really interested in is, how do these abnormalities in glucose tolerance occur, and why do they progress? So here I'm showing you glucose tolerance across the spectrum that I've already described, except here we're giving a meal. On all the slides that I will show you, on the x-axis, so down the bottom, is time. And then we have differences on the y-axis. Here what I'm showing you is blood sugar. In gray are otherwise healthy individuals without CF, and hopefully what you can appreciate is that peak glucose occurs in about 30 minutes, and that by 120, you're even lower than where you were at baseline. If you have CF-related diabetes, your glucose is high throughout. What I want to point out is that these are individuals with what we refer to as normal glucose tolerance, but hopefully what you can appreciate is despite having normal glucose tolerance in the setting of CF, we still have some early glucose abnormalities. Here's that subset of individuals with blood glucose that are elevated just above 155. And then here is that are those same individuals, but I'm showing their insulin secretion. Again, in gray are otherwise healthy individuals, and you can appreciate this peak insulin in the first 30 minutes, and a sort of second, more blunted peak at about 60 minutes. Hopefully, again, what you can appreciate is that there's this subtle decrease in early insulin secretion in that first 30 minutes in people with normal glucose tolerance in the setting of CF, but a later and higher peak at 60 to 90 minutes. If we look now at those individuals with those subtlest glucose abnormalities defined by the OGTT, their early insulin secretion is substantially reduced, as is that second peak. And then if you look at individuals with CFRD and impaired glucose tolerance, their early phase insulin secretion is completely lost. And they have insulin kick out often at 60 to 90 minutes. This has implications for the timing of intervention to preserve insulin secretion and hopefully to delay CF-related diabetes, because we want to catch people early on rather when their insulin secretion defects have progressed. And I'm sorry, I am frozen. There. So now we're going to flip gears and talk a little bit more about that low blood sugar. Often I have patients in clinic who say, Dr. Kelly, I'm feeling a little bit fuzzy, a little bit shaky in the middle of the day, or sometimes they'll be referred to me from their CF providers as a result of these complaints. And here we're often dealing with low blood sugar. In green here are the individuals with hypoglycemia, low blood sugar, and in orange are the no hypoglycemia group. And again, this is in response to a meal. What I'm showing you here is glucose, and hopefully what you can appreciate is that perhaps unexpectedly, the subset of individuals who become hypoglycemic are that same subset who are hyperglycemic compared to that no hypoglycemia group. And again, if we look at their insulin secretion, what you're seeing is this group is losing that early insulin secretion, and they're peaking at 60 to 90 minutes. And as a result of this disconnect between insulin secretion and available sugar, that's why people are becoming low. And clinically, this is really important because we want to make people aware of symptoms of hypoglycemia and the propensity to become low after an oral glucose tolerance test and after fast-acting sugars like sweetened beverages. And so we make the recommendation to avoid those fast-acting sugars. And counterintuitively, this hypoglycemia may be a sign of early hyperglycemia and insulin secretion defects, and maybe an early marker that someone's going to transition to developing impaired glucose tolerance or even CF-related diabetes. So I want to provide some additional details about normal insulin secretion and type 2 diabetes. And I'm going to sort of focus on what I refer to as the incretin effect. Incretins are hormones that are secreted by the gut, and these augment normal insulin secretion in response to a meal. And the two most common, or the two most important, are glucagon-like peptide 1, what I'll refer to as GLP-1, and glucose-dependent insulinotropic polypeptide, more easily called GIP. And this augmentation of insulin secretion is best shown here. If you give an IV bolus of glucose, you have robust insulin secretion. If you gave an equivalent dose of glucose orally, you have even more insulin secretion. And this effect is due to these incretins. Now, if we look at individuals with early diabetes, and as they progress through diabetes, what we see is that you lose your insulin response gradually in response to an IV bolus of glucose, as well as in response to an oral glucose load. And what we found is that this is not due to impaired GLP-1 or GIP secretion. And GLP-1 is less effective, but that's because there's an overall lack of ability to make insulin. But what's really curious in the setting is type 2 diabetes is that GIP does not augment insulin secretion. And many outside the CF world have leveraged this incretins and their ability to augment insulin secretion in the development of type 2 diabetes. And we in the CF world want to know, can we leverage these for people with CF? So let me first show you incretin secretion in people with CF. Shown here in gray, again, is otherwise healthy individuals and their GLP-1 response to a meal. And here in gray is GIP. I want you to focus on pancreatic insufficient in the open circles. And hopefully what you can appreciate is that people with CF have normal GLP-1 secretion, but decreased GIP secretion. And this has been well recognized. And what we do know is that if you take pancreatic enzymes, that your incretin secretion is better. So I always recommend that my patients remember to be faithful to their pancreatic enzyme replacement when they eat, because we also know that improvements in incretin secretion are associated with better blood sugars. So the next question is, can we leverage type 2 diabetes medications in people with CF and abnormal glucose tolerance? And one of these medications that we've tried recently is sitagliptin. And this is a medication that you might hear about on TV. The reason that's attractive is it's an oral medication given once a day. And this medication interferes with breakdown of incretins and causes higher blood concentrations of those incretin hormones, GLP-1 and GIP. So we completed a 6-month study of sitagliptin therapy in people with CF and abnormal glucose tolerance and compared that to placebo. Shown here is the before the baseline, so before treatment, and in open circles is 6 months following treatment. On the left side is sitagliptin, and on the right side is the placebo. And hopefully what you can appreciate is that in response to sitagliptin, there's a really beautiful response, GLP-1 response. And not surprisingly, in the setting of placebo, there's really no improvement in GLP-1. Similarly, in response to sitagliptin, beautiful GIP response, but no response in the setting of placebo. So you get a really nice response, which is expected. Unfortunately, despite that response, shown here, glucose, there really was no great improvement in blood sugars, despite that improvement in incretins. And this is despite what we think is some restoration of early insulin secretion, shown here in those open circles. You're sort of having that restoration of early phase insulin secretion that was not seen in placebo. And it's really unclear why we didn't have a better improvement in blood sugars. And so we're doing more research to begin to look at that. And that's partly shown here. And so what we did, so it's a somewhat complicated slide, is invited individuals with CF and abnormal glucose tolerance to come in for two studies. They got an infusion of a placebo, shown here in the open circles, or GLP-1, shown in the closed circles, or placebo, shown here in the open squares, or GIP. And what we found is a beautiful increase in insulin under this GLP-1 condition, but really unexpectedly, no increase under GIP condition. And this makes me wonder, or made us wonder, if there is an inherent unresponsiveness in the setting of CF. So because individuals responded so beautifully to GLP-1, we've recently started a study in which we are we're recruiting individuals to take a GLP-1 like medication, dulaglutide, which is 1 injection per week. This is used in type 2 diabetes. And we're going to test after 6 weeks the impact of this GLP-1 agonist upon insulin secretion, glucose, and suppression of glucagon, which raises blood sugar, a hormone that raises blood sugar during a mixed meal. And we're going to do this in adults with pancreatic insufficient CF and abnormal glucose tolerance. Additional studies, I think an important question are, what are the priorities for you, the CF community? And those might vary depending upon if you have CFRD or don't have CFRD. And I think a number of the questions that have risen are, can we screen better? Can we make it easier? How should we provide education regarding CFRD? Can we prevent CFRD? Can we improve treatments? And what are the long-term implications of having CFRD? And how do those compare to people with type 1 and type 2 diabetes? So Bryn Marks and Marissa Kilberg began to ask these questions and leverage community voice. And they conducted focus groups in adults and parents of patients with CF, and either with or without CFRD, and identified some key themes and used this to guide survey development that was distributed in June of 2020. And I'm just going to focus on the technologies here. And one thing that came out is that continuous glucose monitoring was really positively regarded and widely used, but there were high attrition rates. And we think that was because of cost and some challenges getting insurance coverage. Insulin pump therapy was perceived as having fewer benefits and greater burdens of use, which is not something that I've experienced clinically. And so I think we need to investigate that a little bit further. What they also found is that if we can get better insurance coverage, perhaps focus on patient education and some confirmation that these interventions improve health outcomes in CF, that we may have better uptake. So what's promising? Well, you've already heard Melissa Putman talk about bone, but I also want to acknowledge that she's leading an effort to try and be responsive to patient needs and make pump use easier. And so she's working with the islet bionic pancreas in CF. And this is a really neat technology in which the insulin pump is integrated with the continuous glucose monitor. Essentially, they talk to each other. And the insulin pump will automatically adjust its insulin delivery based upon the blood glucose from the continuous glucose monitor. And it really requires minimal user input. It doesn't require carbohydrate counting. And so Melissa is conducting a 6-month trial in patients with CFRD to see how effective this is. And with the help of the CF Foundation, she's expanded this trial to multiple CF centers across the country. So then finally, how will highly effective modulators impact CFRD? I think is a really important question. And many of you may know that there's been case reports and case series of improved blood sugars and insulin secretion following the initiation of modulator therapies. There's a recent study using the US and UK CF registries that identified a trend toward lower CFRD rates over 5 years following the start of ivacaftor therapy, and that's shown here. But what we acknowledge is, as CF providers, is that there's probably a balance. So we may see improvements in insulin secretion and insulin sensitivity, but we balance that with improvements in weight that may unmask the underlying insulin secretion defects, better appetite, better nutrient absorption, and aging. And we know that with aging, regardless of your status, that we have declines in insulin secretion. So to get at this a little bit more closely, the PROMISE study is a 24-month study that was started in 2019 in individuals age greater than 12. And this followed FDA approval of Trikafta. And what Mike Salvi and I are doing as part of this study is obtaining a 3-hour oral glucose tolerance test at baseline, 12 months, and 24 months. And what we'll be looking at at is glucose tolerance, glucose excursion, insulin secretory rates, as well as hypoglycemia. And Mike Stalvey, as part of the BEGIN study, is looking at an even earlier age range. And he's looking at individuals age 0 to 6 years. And he's looking first at just natural history, what happens in individuals this young. And then we expect that a subset of those individuals will be put on CFTR modulator therapy. And we'll be able to begin to look at the impact of this modulator therapy upon glucose. And what Mike's using as part of this study is the continuous glucose monitor. I'm going to show you some very preliminary data because some of you may know that as a result of COVID, there's been a 6-month halt in the PROMISE study. And as a result, the 12-month data is only available in a subset of patients. Here, I'm showing you the baseline data, and we recruited a little over 75 individuals. And hopefully what you can appreciate is that there's a really nice spectrum of glucose tolerance that's represented amongst this population. And not unexpectedly, with worsening glucose tolerance, average age tends to increase. And we've been able to break this down with a little bit more granularity, as such that we have individuals with very early glucose abnormalities represented here, that early glucose intolerance. And so here are data on glucose tolerance test in 9 individuals who completed that 12-month visit before the COVID shutdown. In blue are the baseline data, and in red are the 12-month data. What I want you to focus on are that 120 and 60-minute glucoses. Here's that 200 milligram per deciliter threshold, and we have an individual with normal glucose tolerance, early glucose intolerance, indeterminate glucose intolerance, impaired glucose tolerance, and CFRD, and 1 individual with CFRD with fasting hyperglycemia. And we also looked at hypoglycemia, and we had 2 individuals, not surprisingly, who had early glucose abnormalities who became hypoglycemic. Following 12 months of Kalydeco, we had some improvement in glucose abnormalities in patients with CFRD, 2 patients with CFRD. And we also had our 2 patients who had hypoglycemia had improvements in their glucose, and also they didn't have a recurrence of their hypoglycemia during the glucose tolerance test. And this patient with CFRD had great improvements in her pulmonary function and actually had an emergence of hypoglycemia, probably as a result of improvements in her insulin secretion. I want to caution that this is just a subset of patients, and that glucose tolerance does vary regardless of whether one is on Trikafta. It's only 12-month data, and hopefully we'll have more information 24 to 30 months out. And the insulin secretion results are not yet available, so I can't really share with you how these glucose improvements in a subset of patients correlate with insulin secretion. I'm going to highlight that the CF Foundation has been really supportive of studying CF-related diabetes, and there's a number of basic science studies looking at CFRD, as well as a number of clinical research studies. I'm just going to highlight here the bionic pancreas, continuous glucose, and continuous glucose monitoring. I wanted to thank our patients and their families, because without their commitment to doing research, we wouldn't have these data to share with you. And I also wanted to thank the NIH as well as the CF Foundation for their support. And they are sponsoring a CFRD virtual workshop June 23rd, 24th, 25th, that will hopefully inform research priorities and identify knowledge gaps so that we can really improve the care of individuals with CF with respect to diabetes. And with that, I will end. Thank you for your attention.
Thanks so much, Andy, Tracy, Mike, Melissa, and Kara. You guys have been fantastic tonight. We've got time for maybe 1 question tonight, just because we ran out of time. But if you notice in the Q&A, some of your questions have actually been answered already. So take a look at that, and we will actually save those question and answers and make them available to you so that you can actually see those answers if you didn't get a chance to scroll through them. So I think one of the most liked questions is the one I'll go with tonight. I've heard that diabetes does not affect those with CF in the same way long-term versus those with type 1 or type 2. Do we have research showing outcomes in long-term studies? Is it just because we aren't living as long anyway that we don't see as much of the end stage complications? And if outcomes are different, why might that be?
I'm happy to take that question, but if others want to address it, I think we're all equally qualified. I think there's a number of issues. One is that for many patients, the glucose abnormalities are a bit more mild than what we see with type 1 or type 2 diabetes, although that is not true for all patients. I think we haven't seen patients with CFRD for long enough time to know. Many of us on this panel recognize that this is a really important question. What are the impacts upon kidney, upon eyes, upon the stomach? Some people think that patients with CF are protected from what we refer to as macrovascular complications, so heart disease, as well as maybe stroke, because we don't tend to see the lipid abnormalities, the high cholesterol in patients with CF. And there hasn't for many years been a tendency for patients with CF to be overweight or obese. We don't know if that's going to change with modulator therapies and with aging, but many of us are asking these same questions. I welcome other input from my colleagues who probably know a lot more about this than I do.
Anybody else want to chime into that one?
I couldn't have said it better myself, Andy. I think that's exactly right.
Well, unfortunately, we are out of time tonight. I want to thank the Cystic Fibrosis Foundation for putting this together. We're very grateful for it. Jen just started sharing a screen for us that you can see some of the upcoming topics that Community Voice is putting together. And you saw a link in the chat for people to sign up for Community Voice. I'm a part of it, and personally, I love getting to be a part of this research from the comfort of my own computer, which especially in this pandemic has been very, very helpful. Thank you so much to each of you, our presenters, for being a part of this tonight. Thank you to you for participating. And I hope you will join us for the end of tonight back with our co-chairs in the main area of ResearchCon. And we hope to see you on Saturday as well at the roundtables that are taking place. Thanks so much, guys, and have a fantastic night.